Welcome all to the ISA academic session. We have been running this ISA online PG classes since almost 1.5 years, every Mondays without fail. And it's a pleasure to welcome our international faculty led by Dr. Shalini Dheer. And I'm thankful to Dr. Harsimran Kaur also for coordinating. With profound pleasure, I hand it over to Dr. Sukhvinder Bajwa, our new Honorary Secretary, to carry it forward from here. Dr. Sukhvinder Bajwa, please.
Thank you, sir. Good evening, everybody, especially our international faculty, Dr. Shalini ma'am, Dr. Christopher, Dr. Deepti, and my all regards to our President, sir, Dr. Bhimeshwar, and our immediate past President, Dr. Venkatagiri, then our Vice President, Dr. Mahesina, and our very dynamic, just immediate past Secretary, Dr. Naveen Malhotra, who has been carrying this program for a long time, almost 1.5 years. It started around on the 1st July 2021, and it has been running very successfully. The importance of an organization is always reflected upon its, the academic programs, the classes, the online classes, which have been running almost every Monday without any interruption. I think they were a runaway hit with all the viewers, and their lectures have been still recorded on the YouTube also, which are available on the website. And continuing this thing, now passing the baton, he has passed the baton to me with the new academic session beginning. These classes are dynamic, and what a way to start with international faculty there. We are starting our next session of the academic program from them. Coming to my own, this one, whatever the position I've got today, it is the faith reposed by my countrymen, this NSCF fraternity, and I will live up to their expectations, whatever they have from me, and whatever the ISA has done over the last 3-4 years. It's a wonderful. It has started making its niche in the world, in the global level and the academic arena. And our aim is to make it more globally visible academically, and with the coordination from academicians from all parts of the globe. So that will be our new mantra from the next year onwards, from this session onwards rather. And I welcome everybody from all the GC colleagues also. And I wish that such programs will keep on happening. Apart from the PG classes, we will keep inviting the international faculty who are of high repute, and we will be enriched by the knowledge. And there's a time has come where the knowledge from different countries has to be amalgamated, which you may not be able to find in the journals, or maybe may not be found in the books also, because the present experiences, the medicines is evolving, especially after the COVID era. Now the new things are coming up, the new medicines are coming up, the post-COVID era. That's what I'm saying. Similarly, even the ISA also, the last 3-4 years, the level has reached such a height that it will be a challenging task for me. But I have got 3 past secretaries in my GC at the moment. My president, Dr. Bhimeshwar, Dr. Venkatagiri, and Dr. Naveen Malhotra, sir. All are dynamic, and I know we will take together this ISA to a new heights in academics. Thank you, sir, for at least conducting my first program on my tenure. And I think I will be able to live up to expectation, what you have, the standard you have set in the academic area. Thank you very much.
Thank you, Dr. Bajwa. Now I hand it over to the coordinators for today's programs, Dr. Nishant, Dr. Monica, Dr. Ankur Khandelwal, and Dr. Harsimran Kaur. Dr. Nishant, please.
Thank you so much, sir, and a very warm welcome. May I cordially invite Dr. M.V. Bhimeshwar, sir, President ISA National, for the ISA flag hoisting digitally. Dr. M.V. Bhimeshwar, sir, please.
Yeah, good evening, everyone. Now the flag hoisting, please. Let us do the flag hoisting of the Indian Society of Anesthesiologists. Naveen? Thank you, everyone. Thank you, everyone. Now it's my pleasure to welcome all of you for this starting of the academic session year 22-23 with the first webinar where we have wonderful faculty who have come. And it has been going on for the last 1.5 years. And I'm sure with our new secretary, Dr. Bajwa, the chairman of the academic committee, Dr. Venkatagiri, will go still further. And I wish the function all success. Thank you.
Thank you, sir. May I request you again, Dr. M.V. Bhimeshwar, sir, President-elect ISA National, to formally inaugurate the ISA academic session 22-23 by lighting a lamp digitally. And may I request all the dignitaries present to also join in, please. Dr. M.V. Bhimeshwar, sir, and all the dignitaries present, may we please light the lamp digitally?
Yeah.
कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः
Right, Dr. Monica, thank you, sir.
Dr.
Dr. Monica, you
Okay.
muted, please.
Can we mute everyone?
Good morning, sir. Good morning, everyone. Good evening.
So
Good evening, ma'am.
now I cordially invite.
Over to you, Monica. Unmute yourself. Monica, unmute yourself.
So now I cordially invite Dr. Venkatagiri, Chairman ISA Academic Committee, to address the House. Dr. Venkatagiri, please. Sir. So please unmute yourself. So still muted, sir, Dr. Venkatagiri.
Dr. Giri, unmute yourself. Dr. Giri, unmute yourself.
Okay. Thank you.
Yes, sir.
President Dr. Bhimeshwar, GC colleagues, faculties, and friends. It's a good beginning that we are starting within a week of taking over the new officers, this academic program, continuing from the last 1.5 years or so. Hope that this year we'll have more programs, and what I suggest is that we will have more interactive programs than more one-sided monotony lectures. Let us have more interactive, and as Dr. Bajwa told that we have more international faculties. If our members are allowed to interact and talk with them, because they can get these lectures more in the YouTube or other thing, but interaction and giving their experience and action will be more beneficial for both the PGs and practitioners. I wish in this year we will have more and more interactive academic sessions, and every PG and consultant will get benefit from that. Hope that we can find some way to have it more interactive. With this, I thank you, all the faculties, and wish to have more and more interactive programs the coming year. Thank you. All the best.
Good evening, respected faculty members and dignitaries. I now cordially invite Dr. Mahesh Sinha, sir, Vice President, ISA National, to address all the delegates.
Good evening, everyone, Mr. President and the whole of the Governing Council and the invited faculties from the abroad. It's a new beginning with the new team. Some members are old, some members have joined recently. So this program has been running very nicely. We learned a lot of things during the COVID, and one of the things is the online education and learning. I think is goes far beyond than that and help everybody. Thank you.
Thank you, sir. We also have respected JV Divatia sir with us, the President-elect ISA National. May we have some words of wisdom from you, sir?
Good evening, Mr. President, sir, Mr. Secretary, members of the Governing Council, our distinguished guests from Canada. So it is indeed a great pleasure and honor to be here at this webinar. It's the beginning of this season, but it's actually a continuation of all the work that's been happening over the past few years. And it's a great pleasure to be associated now with this Governing Council and to start off with this extremely distinguished faculty who will be speaking to us this evening. So I wish all of us, all members, all the very best. And I'm sure we'll be enriched by this experience and by this format of teaching. Thank you very much.
Thank you, sir. Now I'll invite Dr. Manoj Kumar, Treasurer, ISA National, to say a few words. Dr. Manoj, please.
President Dr. M.B. Bhimeshwar, sir, Vice President Dr. Mahesh Sinha, sir, Honorary Secretary cum Moderator of today's function, Dr. Sukhbinder Bajwa, President-elect Dr. J.B. Divatia, sir, Editor-in-Chief and of IJ, Dr. Rakesh Garg, Chairman ISA Academic Committee, Dr. Venkat Giri KM, sir, Immediate Past Secretary Dr. Naveen Malhotra, sir. Today, three eminent speakers from Canada, Dr. Shalini Dhir, Madam, Dr. Christopher Hansbert, sir, Dr. Dipti Vasa, Madam, all GC member of ISA National, all the office bearer of State and City branch of ISA, all member of ISA, and all postgraduate students. Good evening and very warm welcome to all of you on the occasion of inauguration of the ISA academic session of this year. As you all know, education is the most powerful weapon which you can use to change the world. In this context, ISA always organize academic activity in many ways. I am sure under the dynamic leadership of Dr. M.B. Bhimeshwar, Sir, President ISA National, Dr. Sukhbinder Jeet Bajwa, Honorary Secretary ISA National, and all the GC members, our ISA flag will flying high. I wish you for grand success of ISA academic session 2022-23. Thank you so much. Over to you.
Thank you, sir. Now I cordially invite very dynamic Professor Rakesh Garg, our new Editor-in-Chief, Indian Journal of Anesthesia. Sir, a few words of wisdom from you, sir.
Thank you, Dr. Ankur Khandelwal. Respected dignitaries, President ISA Delhi, Vice President ISA Delhi, President-elect, Honorary Secretary, all the Governing Council members, respected past office bearers, past President ISAs, state and city branches, senior ISA members, colleagues, and dear friends. I think ISA, one of the important aspects of any society is to provide an academic platform for enriching and updating the knowledge to all the ISA members. And ISA legacy in the past has always been in this direction always. And I am sure that this new team will take this legacy forwards so that we can always bring forward the eminent distinguished faculties, not only from India, but outside India, like today's webinar,
so that all of us, all the ISA members can take the word of wisdom, the updating of knowledge from all those things, all those eminent personalities into our clinical practice. And finally, we are working for our patients, for the good of our patients. And I'm sure these webinars will bring us or will make us more wiser. My best wishes to all of us. And I'm sure that in the near future, this legacy will continue and will take it to a newer heights. Thank you so much.
Thank you so much, sir. With this, we begin our academic session with a talk by Dr. Shalini Dheer. She'll be talking on abdominal facial plane blocks. And I'll take pleasure to introduce her. Dr. Shalini has done her undergraduation and post-graduation from Meerut University, India. Thereafter, she has done a fellowship of Obs Anesthesia and Regional Anesthesia at Western University, London, Ontario, Canada, from year 2004 to 2006. She has also done a degree in anesthesia from Canada and her master's degree in clinical management of pain at Edinburgh University, UK. Presently, she has been an anesthesiologist in the UK and the Emirates and a faculty in 2006 in Department of Anesthesia and Perioperative Medicine at the Western University. At present, she is Associate Professor of Anesthesiology and Perioperative Medicine. So, so my screen is visible.
Yeah, Monica is fine. You just invite ma'am for the lecture. Now she has to leave. I think she has sent a message.
Yeah.
So even 35 minutes.
I invite ma'am to enlighten us. Ma'am, please.
Yeah, you have to allow me to share my screen.
It's allowed, ma'am. You can share.
Can you see me? My screen?
Not yet, ma'am.
Because it says I'm sharing. Share screen.
Please open your presentation now.
Yeah, that's what I'm saying, but I'm not able to share. When I click the share button, nothing happens.
Ma'am, please open the presentation first and stop screen sharing. Open your presentation first and then again share the screen.
Yeah, my presentation is open, but the moment I play, then this thing goes away. No, this is a problem.
What is coming on tapping the share screen? What is coming?
There are two things, entire screen and window. Entire screen.
So, madam, you do one thing. First, open your PowerPoint presentation separately.
Yeah, I've opened it already.
And then go. Don't open it in a folder. Open it separately. Your PowerPoint presentation is open?
Yes.
What is a slideshow?
It's a slideshow. When I do play, then it's my whole screen is my PowerPoint, then I don't see you guys.
That's fine.
So
please share.
But I need the button to say share screen, isn't it?
Ma'am, don't make it full screen. Just listen to me quietly. Don't make it full screen as of now on your computer. Let it be open and then share screen. Let's see what is visible. First, you share the screen.
Yeah, I'm sharing the screen. Yeah, it says please grant browser access. God, this is terrible. Has it got something to do with the fact that mine is a keynote, not PowerPoint?
Yeah, ma'am, it doesn't matter, but still it has to be shared.
Yeah, I understand that, and I have done a lot of Zoom presentations. So it's not that I'm learning today, but when I say I can either, even when I'm saying share entire screen,
What is
You
coming?
can you can do one thing, ma'am. Leave and rejoin. Sometimes this helps.
yeah, let me do that.
Dr. Harsimran, are you there with madam? Or you are at a different place?
She has rejoined. Please make her co-host.
Madam, you can unmute yourself and now try. Unmute yourself and try.
Hello, sir. I'm at a different place. I am at home. I'm just able to unmute myself now. Mhm.
Can you see my screen at all?
No, madam.
Oh, God.
But Christopher, you are able to do it. Just check.
Sure, yeah, let's have a look.
Can you share your screen, Dr. Christopher?
I'm trying to. Can everyone see it now?
Yes, I can see your screen.
Do you want it? Why don't you send me your slides quickly? And
Yeah, let me do
since
that.
It's working. Yeah.
Yeah, let me do that.
And then we'll get it done.
Yeah.
Hi, everyone. Morning.
Thank you. Thank you for the help.
Could not be attached. I think we will have to, I don't know. Did you get it?
Yes. Just wait. Oh, I got an email, but I don't see any attachment. I don't see any attachment, unfortunately. You could upload it to Teams.
You have Keynote, Chris?
Keynote.
No, because
might.
it's a Keynote, so
Yes.
therefore it won't open.
I have Keynote. I'm just opening it for the first time, but it's opening. I've got a Mac. Do you have Dropbox? You could share a link with me.
This is like by the time it comes, my time to go will come. I think we should have checked all this. I should have checked it, and fault is mine. I should have checked it before. I don't think it's working. Let me just send to both of you, Chris and. Did you get something, Chris?
You sent it to the LHSC email?
Yeah.
Okay. Keynote presentation. I think so, yes. So I'm just needing to log in through LHSC, I guess, to get it. Give me a second here. Yeah, I gotta verify. I think it's working here through SharePoint.
Excellent.
Yeah.
Excellent.
Okay. Yeah,
It's done.
I've got it now. Just gotta download it. All right, let's get this show on the road. Share screen. Wait, sorry, it's downloading, almost downloaded. Okay, there we go. All right, keynote. And let's share screen. Keynote presentation. Okay, just let me know when you want the next slide.
Play. Yeah, play now. Yeah, keep going. Good morning, everybody. I'm so sorry about this technology mishap. I'm Shalini Dheer, and I'm going to really run past because I have another meeting. So I have no conflicts. I'm going to talk about, and thank you everyone for inviting me. Thank you, Harsimran, for organizing this. And thank you, ISA. In the next 25 or rather 20 minutes, I'm going to talk about, keep going. Some concept, a little bit of opinion, some evidence, and some knowledge gaps that are present in abdominal facial blocks. When we talk about evidence, hierarchy of evidence, everybody knows this triangle, and we will come to this triangle towards the end of the presentation to see where we lie in the hierarchy of evidence when we talk about abdominal facial plane blocks. Yeah, we'll bypass that. Yeah, keep going. So how did all abdominal facial plane blocks begin? It was 2001, Rafi published in Anesthesia, a landmark guided technique of TAP block. The TAP actually, he used word between planes, and the TAP word was coined by O'Donnell in 2006. Go on. Since that time, there is a barrage of landmark guided, ultrasound guided, case series, RCTs. They have all coming. Keep going. And now every morning I get up, there is a new one. So there's a bit of definition of fascia. What do you mean by fascia and what do you mean by plane? Fascias are sheets of biological fabric that actually divide different body structures. What about plane? Plane is not this plane we are talking about. We mean plane. It's an imaginary 2 to 3 dimensional surface that describes a view. So that's what we mean by plane. And fascia is a complicated structure. Keep going. And it's got a lot of variations. It's influenced by abdominal and thoracic pressures, and there are different thicknesses and also influenced by other fascias in the neighborhood. It's a cool fact. The group of muscles and nerves are wrapped in a layer of fascia. There are muscles within the same compartment, and the muscles in the same compartment are innervated by same nerves. So there are no specific targets, but there are adrenergic elements that influence blood flow as well. When we talk about fascial plane, it's actually a misnomer because we are not injecting drug in the fascia. We are actually injecting the drug in between two fascias. So the right word to use is interfascial plane. That's the correct word. When we talk about fascial plane, that's a misnomer. The mechanisms of actions are really unknown, even though we do know that there are nerve endings. Next one, please. where is the local anesthetic action? Some people say it's on the nerves in the interfacial plane. Then it could also be nerves in the nearby planes, and then there is systemic absorption. Now, when in 2011, there was a study on the spread of local anesthetic in TAP, and they proved that the TAP actually works by absorption into the paravertebral plane or paravertebral area. So there is an alphabetic soup with abdominal interfacial plane blocks. There is TAP, many blocks, many names, ESP, QI, ilioinguinal, iliohypogastric, and so on and so forth. Let's come with, that's okay. That's okay,
Sorry.
Chris. No, I know. Let's just, we'll just restrict ourselves to the abdominal blocks, even though there are a lot of other fascial plane blocks. Let's talk about TAP. We know a lot of people, most of us are very well versed with this block. Now, use of ultrasound became very popular between 2008 and 2010, even though it was introduced much before. And during the same time, it was only with the help of ultrasound that the posterior TAP, subcostal TAP, lateral approaches of TAP became popular. So in 2021, there was a TAP versus epidural. That was 18 RCTs, nearly 1,300 or 1,220 patients, lot of heterogeneity, bias. The evidence was low quality. There was high opioid consumption, but low hypotension when they were comparing it to epidural. Then in anesthesiology 2019, a narrative review came. They said that it's a valid postoperative analgesic action, but in open appendectomy, possible CS, but not useful in laparoscopic procedures. Now, for all you researchers out there, further studies are needed in open procedures and comparing it to other truncal blocks. So that is something to look at, even though TAP does seem to be an older interfascial plane block, there are still not enough studies. Next. What we know or we do not know about TAP as of today, we do not know that landmark or ultrasound which is better. Should it be by surgeon or should it be by the anesthesiologist? Now, if the surgeon puts in, definitely there is less time involved. What about what is the ED50 or MEV? That's unknown. There is evidence that there is good analgesia with large volumes, but very minimal difference amongst concentrations. Should it be continuous? Should it be intermittent? Should we have adjuvants? Not enough studies. There's high risk of LA toxicity. Where did I go? And you should consider lean weight rather than absolute weight of the patient when we are doing TAP or weight-based doses. Next, please. So to summarize TAP, there is scarcity of evidence, contradictory findings, studies are needed, and there is no proof that the benefit of TAP block persists beyond multimodal analgesia regimen. So that would be a nice one to study, TAP in addition to multimodal, TAP without multimodal, or multimodal without TAP. Okay, let's come to the very famous erector spinae block that everybody is raving about. It was introduced first time in thoracic neuropathic pain in 2016 by Mauricio and Sanjeev from Philadelphia. Next one. In 2019, there was a cohort study, 79 patients with rib fractures, modest reduction in pain scores, insignificant, but there was a reduction, but insignificant reduction in opioid consumption, improved inspiratory capacity, and at that point they said needs RCTs. So it was a cohort study. If you remember the triangle, the hierarchy triangle, we are in the cohort study level. 2019, there was a case series, 5 anticoagulated patients, same group of researchers with LVAD, and the pain management was very successful. 2021, there was a systematic review and meta-analyses, 12 RCTs, nearly 700 patients. Short-term benefits were there, reduction in opioid and side effects, but clinically unimportant. Did not support the use of erector spinae. This is not me saying, this is the systematic review and our meta-analysis saying. 2019, there was another one in Minerva. That was a qualitative analysis, 126 patients. And when we did a quantitative, it was 242 patients. They found lower opioid use, but heterogeneous endpoints, so no analysis. So therefore, there was no solid recommendation, de facto option. What do you mean by de facto? De facto means practices that exist, but are not officially recognized. So erector spinae is considered a de facto option. In 2022, which is this year, Journal of Clinical Anesthesia did another systematic review, 12 studies, nearly 700 patients in lumbar spine surgery, low pain scores, low opioid use, low side effects, and heterogeneity and low-grade evidence. Like, remember in the beginning, I told you about where the RCT gets published. That is very important, because if you have low quality evidence, then most good journals will actually not publish it. Let's come to the quadratus lumborum. I'm not sure how many of you do it. Next one. It's a newer interfascial plane block of the posterior abdominal wall, and local anesthetic is in between the thoracolumbar nerves. And there are many ways, QL1, QL2, QL3, and all these QL became important with the use of ultrasound, whether you put the drug anterior or posterior or in the middle of the through transmuscular QL. Lot of publications on QL, on concepts, mechanisms, reviews, 2017, 2018, 2019. I think there was a bit of lull because of COVID, and not many things got published in 2020 about these new techniques. Go on. So there is cadaveric evidence that there is direct spread to lumbar plexus. There is no consensus on the type, local anesthetic concentrations, volume, or additives. It is a good part of multimodal technique, especially in abdominal, gynecological, or obstetric procedures. In terms of clinical evidence, there are very few case reports and even fewer RCTs. So evidence is weak but growing. However, one must understand that it will provide dermatomal coverage for abdominal surgery, may spare or reduce opioid consumption. Its role in hip surgery, not much difference has been seen in hip surgery. What about systematic review of?
Sorry.
Yeah. Uppal et al. From Dalhousie in 2020 in Canadian Journal, they published for an systematic review, 42 RCTs, some high risk of bias, significant heterogeneity, and different QL variants. They were not, all of them were put in one big bag and it compared. In CS delivery, they found reduction in opioid use, but no change in pain scores. In other surgical procedures, though, there was change in pain scores as well. And they concluded that there's marginal benefit when compared with other regional techniques. 2021, another one came out, 31 RCTs, 51 citations, nearly more than 2,000 patients, CS delivery, QL versus TAP, with intrathecal opioids, they found that there's not much benefit. So the gold standard intrathecal opioid it didn't add anything further. Both were better than control, and without intrathecal opioids, there was equivalent analgesia. That's a good thing, though, equivalent analgesia. Again, 2021, another study in European journal, decreased opioid consumption, increased time to rescue, and decreased PONV, postoperative nausea, vomiting. Lot of them 2021 and from 2020 to 2022, 13 studies, 9 studies, 7 trials, 22 studies, lot of studies. So nearly more than 5,000 patients now, if you calculate them. Go on. What can I say? There have to be studies, QL versus TAP, QL versus GA, QL versus other blocks, QL versus neuraxial opioids, QL versus whatever. And all these studies, they have significant heterogeneity, high risk of bias. There is some benefit in renal surgeries and C-sections, but limited evidence in other surgical procedures. And therefore, again, to all you researchers out there, more studies are needed. That's okay, that's all right. Rectus sheath block, I don't know, a lot of people don't do rectus sheath blocks. I think they are a good. Next one, Chris, please. They're a good option, especially for midline surgeries. Now, this is a review that came this year in Journal of Perioperative Practice. Similar effect to epidural, and favorable side effects. But however, remember, this is Journal of Perioperative Practice. It's a very low impact journal. And same for Journal of Surgical Research, reduced pain scores. So these are weak studies, low impact factor journals, and no definite conclusions can be withdrawn. Ilioinguinal, iliohypogastric. Again, 2019, there was an article in Journal of Medicine that speaks for itself. No anesthesia journal published it. No difference in opioid use, time to analgesia, satisfaction, but lower pain scores. Again, low quality RCT, no long-term follow-ups were there. So this was a study again in Helion journal, not indexed, when they compared it in post C-section plain, compared with TAP, and they found no difference and recommend either. So where are we now? Just to summarize now, where are we? Interfascial plain blocks are still in infancy, limited knowledge. Interfascial plain, they are large spaces. We do not know where we should inject. Local anesthetic is not as predictable. We all know, not like plexus blocks. And we need retrospective cohort studies and outcome studies. There are unanswered questions.
Oh, geez, sorry.
So these are 3 articles that actually they're not systematic reviews, but they discuss interfascial plain blocks. They are very good articles, and I would recommend you read them. Next one. So are they unanswered questions? Do they enhance bowel or blood flow recovery? Are they safe? Are they predictable? What about local anesthetic toxicity? Will they replace thoracic epidurals? Will they reliably anesthetize sympathetic nerves? Do they address visceral pain? Those are the questions that need to be answered. So if you click another one, Chris, this is where we lie with the interfascial plain blocks in the meta-analysis randomized controlled trial section. They have not reached the clinical practice guideline tip of the triangle. Excellent. I think mine is finished. Is it?
Thank you, Dr. Shalini Dheer, and I'll request Dr. Bajwa, Dr. Devetya, and Dr. Garg to carry it forward from here because she has to attend one more meeting. So over to you.
I still have 5 minutes. There was another slide after this, which probably didn't go through. What if they are the takeaway lessons learned here? The takeaway lessons are they are not standalone techniques, possibly part of multimodal analgesia, do not match visceral coverage, and they are not long lasting as plexus or epidural. I still have 5 minutes. I can take questions.
So right now, I think if there is one question, madam, what will be the toxic dose when the local anesthetic drug is injected into the interfacial plane block? So is it as same as the perineural injection? Or
Not perineural though, but local anesthetic toxicity. Yes, we have to abide by those rules, and that's why more and more people are diluting it further because to increase the volume. Because what the studies have shown is that concentration is not as important as the volume. So in my practice, I only use 0.25% or 0.2% when I'm doing a fascial plane and use big volume.
And second thing, usually this is a comment from the surgeon colleagues, surgical colleagues. If you are using a facial plane block in the same plane where they are doing surgical dissection, sometimes they are a little concerned about the fluid that we have injected there, that it comes into the surgical plane. This is one. Second, especially when you are going for, say, oncosurgical procedures, are we breaching the plane from the oncology point of view? So these are two concerns which sometimes surgical colleagues. What's your opinion, madam?
And very good question there. You know, in our hospital, what we have started doing, especially for renal transplant, is actually we allow, because surgeons are a little worried about us meddling around in the same plane that they are working. We have the surgeons putting in TAP catheters now. Again, with the fascial plane blocks, you know, single shots, they can only last as much. So we are putting TAP catheters, but we are allowing the surgeons to put in the catheters. So they are happy because they are doing it. We are not doing it. And there has to be a sweet spot in between. Onco, yes, I don't do a lot of onco surgery. And yes, that's a very valid question for which I don't have the answer, whether we are breaching the plane.
Yeah, so I think what the literature says, madam, if we are going into the same plane where the surgical dissection is required, probably it can be avoided. But in certain procedures, like for example, the ESP block, probably the infusion site or the needle prick site is away from the surgical site. So I think it should not be a big issue.
Yeah, agree.
And what's your, yeah.
Now, first of all, I like to congratulate you. You have very honestly described the heterogeneity about all these studies. That blocks are evolving. The volume, this will remain a question. Since we are using the ultrasound now, even that may not be accurately defined how much volume we can be used. Because every pathophysiologically, the planes are different in different gender, at age, the absorption mechanisms and how the drug really acts. That's a very different thing. And
that's true. And we should not forget that the interfascial planes are like a sieve. You put the drug in and the drug will sort of go out.
Where it moves, where it really acts, that how it, and these studies which have the evidence which has accumulated till now, we can say certainly that this amount of the drug has to be given, that this much concentration has to be given at this particular point, it has to be injected. But I think in the times to come, with the more RCTs, and with the more meta-analysis from the RCTs rather than from the retrospective studies or observational studies, the RCTs will give a better evidence, and when the meta-analysis will be done from those studies, then we can at least say with some certainty which you have described. What can I say? Where we are now? I think those are very pertinent questions about these type of blocks. At least anyway, we are evolving, and it's a very honest, confession at the end. And that's a way to give a very good lecture and to everybody. And I ask the house, anybody has got a question here? Anybody?
I think somebody called JP has a question.
Respected ma'am and sir, all the audience members are currently muted. So they are encouraged to type their questions in the chat box itself. The moderators, honorable moderators will discuss it with the speakers maybe.
I'm not able to find any question here.
They've got the option to unmute themselves and interact directly also.
Dr. Jay, you can unmute and ask your question.
Jay, unmute yourself first. Unmute yourself.
He's not able to unmute, I think.
Yeah. Okay.
Now, everybody can unmute themselves and interact with madam.
Yeah. Good evening, ma'am. Dr. Shalini, ma'am. Actually, you have so many slides of that meta-analysis, and most of them articles I read that one because I'm interested that in meta-analysis and all those systematic review, and 4 or 5 articles because one article you have shown that iliohypogastric and ilioinguinal versus if you will look at in comparison with the tab block, if you will look at that subgroup analysis, it was very different. That's why I felt that you will show that forest plus also, because many meta-analysis without seeing that, and all things we can't remember. So without seeing that the forest plot, we can't analyze that.
That's true. That is true. But remember, TAP is partial ilioinguinal iliohypogastric block. So I think, and this is my clinical sense, that I don't think we will be able to really separate the two and find a real difference between the two.
If we look at both the subgroup analysis heterogeneity in separately, it was significant. But
I'm trying to say is when you are actually doing the block, have you just done a TAP block or have you done an ilioinguinal iliohypogastric? That's what I'm saying. Once you publish, that's a different story. And yes, your forest plots are very important criteria.
So I feel that you will show that forest plot in next slide. So I was waiting that.
I had so many blocks to cover.
Dr.
Yeah,
Jay,
so please
Dr.
show
Jay,
that.
even the statistical part you're talking about, either it's a forest plot or any other statistical part, but still we are able to convince ourselves clinically in these type of blocks. She has rightly mentioned that it's a C. The C, that how the drug really spreads out properly, either you do the hemodilution studies or some other studies where, or you can use the isotope studies where you can actually get the real effect of the drug at particular site concentration. Then only we can say about the accurate statistical technique can be applied at that time. But anyway, this is a good discussion today, and ma'am has to go. I think.
I've put my email there. So if anybody wants to ask a question, then you can email me. Right now, I have to attend another meeting. So I'm so sorry, Chris. I'm sorry I won't be.
No, ma'am. Thank you very much for part of our this webinar, and it's a good beginning. And we are proud.
I hope I'll be involved in many more.
Really honored, ma'am, to have you here. Yeah. Thank you very much.
Thank you.
We look forward to more interactions with you.
Yes,
as Dr. Achal Dheer had also joined us a couple of months ago for a liver transplant webinar. It was a pleasure having you here, Dr. Shalini Dheer.
Thank you. Thank you.
Back to the moderators, please.
Yeah.
Thank you, ma'am, for the informative session, and thank you for joining our program today. It's my pleasure now to invite our second speaker, Dr. Hansebout, Christopher Robert Hansebout.
Good morning, everyone. My name is Chris Hansebout. I work along with.
I'll introduce you, sir. So, sir is currently assistant professor in the Department of Anesthesia and Perioperative Medicine, Western University, Schulich School of Medicine, Ontario, Canada. Highly qualified, and he has a couple of fellowships under his belt, like perioperative echocardiography and ultrasonography, regional anesthesiology fellowship, adult critical care fellowship. He has multiple indexed publications, and I do remember one, the famous local cooling of the traumatic spinal cord injury. I myself, being from the neuroscience background, that was a very highly cited article. Thank you, sir, for bringing it out. He has presented his works in various conferences. He is a member of various professional societies. Apart from research, academics, and teachings, he is also very keenly interested in music and athletics. So we welcome you, sir, to our ISA program. Hope we enjoy your session. Over to you, sir.
Oh, thanks very much for having invited me. I'm going to attempt to share my slides now. Hopefully I'm able to accomplish that. And can people see what I'm looking at here, the slides?
Yes, we can see, Chris.
Okay, great. All right, so I'm going to be talking a little bit about enhanced recovery for shoulder arthroplasty. I have no conflicts of interest. Just wanted to mention that there is an ERAS society, and this presentation isn't endorsed by it. So in general, I'd like to take a couple minutes to describe the ERAS principles, discuss what evidence exists, such as it is for ERAS and shoulder arthroplasty, and then just briefly describe a couple regional anesthetic techniques that might be of value in facilitating postoperative analgesia.
Chris, you have to make it a full screen slideshow.
Oh, it's 1 second. Let me try this. That look better now?
No, Dr. Christopher is still in the this one small screen. You have to start the slideshow.
Yeah, I see what I'm doing wrong here. 1 second. Where is the I see. Slideshow play.
Yeah,
that right? Okay, there we go. Great, thanks. So first off, what's ERAS? Functionally, surgical patients journey through a variety of different hospital places in the hospital clinic. Each of these specialized areas has their own personnel focus, and staff often sort of tunnel in on what they consider to be their sort of the most immediate or pressing clinical concerns. There are often not very many stakeholders who actually see a patient through the entirety of their surgical journey or perioperative journey. So the ERAS is a process which attempts to bring together all these various stakeholders and cause them to sort of agree on certain important management endpoints. Ultimately, the idea of ERAS is the main goal of ERAS is to minimize surgical stress and improve the patient's response to it by doing things like ensuring adequacy of analgesia, decreasing surgical complications. And functionally, what we want is for patients to be able to, leave the hospital and go home and take care of themselves after the surgery, and to be able to do so as quickly as possible and as safely as possible. A portion of the ERAS process is also quality improvement, so basically auditing outcomes. From a historical perspective, ERAS concepts were initially applied to colorectal surgery in the early 2000s based on some concepts developed in cardiac surgical patients in the 1990s. It's now been expanded to include a variety of different surgical procedures. So there's oncologic surgery, bariatric surgery, obstetric, cesarean delivery. And importantly for us, or for this lecture, I should say, some orthopedic surgeries as well, mostly including hip and knee arthroplasty and then lumbar spine fusion. There we go. Not to assault you with a wall of text here, but just to say that this is a summary table of an ERAS guideline for total hip and total knee arthroplasty. Involves 17 recommendations spanning the pre, intra, and then post-operative course. They describe various areas of intervention as they describe it, including things like preoperative education and counseling, optimization, local anesthetic, infiltration or block, and then prevention of blood loss, prevention of thrombosis, maintenance of normothermia, and providing antimicrobial prophylaxis, and then finally early mobilization, criteria-based discharge, and that auditing that I mentioned earlier on. Have the application of these ERAS concepts been useful to surgeries, or been useful to patients? Well, like I said, the goals are to decrease hospital length of stay, decrease complications, and decrease readmissions to hospital. In colorectal surgery patients, which are probably the most studied because it's the oldest, it was shown to decrease hospital length of stay with a trend towards decreased complications. And in orthopedic surgeries, so hip and knee arthroplasty, it again decreased length of stay by about 1.5 days and managed to decrease overall complications as well. So I would say that when we are comparing the utility of an ERAS program, most of the studies basically involve a single institution comparing their outcomes post-ERAS implementation to what their outcomes had been pre-ERAS implementation. So it's not really looking at non-ERAS hospitals as compared to ERAS hospitals, it's typically looking at, a hospital that has decided to implement ERAS, and they're looking at their outcomes before and afterwards. And here's a forest plot, which should make at least one audience member happy. Joke there. Man, it's hard doing things online. There's just so little feedback. Okay, so in terms of ERAS for shoulder arthroplasty, can ERAS meaningfully impact outcomes in shoulder arthroplasty patients? Well, this is table describing mean length of stay after shoulder arthroplasty for patients at a variety of different trusts or hospital systems in the United Kingdom. Going from the left side of the graph where hospitals have the shortest length of stay to the right side of the graph where they have longest length of stay. And sort of most hospitals or many hospitals might find themselves within that between those, that blue line at the bottom and the purple line at the top. And that's sort of the minimum and maximum expected. So, it's expected that, most patients should stay somewhere between 1 and 4 days. At the max, with an average of maybe 2.5-ish. There are still a variety of hospitals, at least in the UK, where the average length of stay is actually over 4 days, and some hospitals the average length of stay might be 7. Now, this is pretty crude data, because there's lots of reasons that you might argue if you were a hospital administrator, saying that you're looking after the most complex patients or the sickest patients or something along those lines. But functionally, I would take from this that safe reductions in length of stay at least have the potential to significantly, to decrease healthcare costs for these hospital systems, or at least for some of these hospital systems. And so ERAS principles could probably be applicable to shoulder arthroplasty. So, but shoulder arthroplasty, I won't spend a huge amount of time on this because I'm sure everyone has some understanding of what it is, but functionally it's the definitive treatment to painful end-stage shoulder conditions after failure of conservative treatments. And the goal is to allow complete functional completion of activities of daily living with a significant reduction of pre-procedural pain. And the hope is that these replacements will also be durable. Often they're successful beyond 10 years after completion. So shoulder arthroplasties might be great, and they might allow people to gain a significant amount of function. But analgesia, particularly in the immediate postoperative period, can be quite challenging, and especially so if this pain is attempted to, if pain is managed with opioids alone. This can actually result in prolonged admission if analgesia is inadequate, or if opioid-related side effects develop. There's also some indications that severe postoperative pain can be associated with the development of later development of chronic pain. And so I would argue that immediate analgesia in the immediate perioperative period might be impactful, and I'll get a little bit more into that in a second. So in terms of how we provide anesthetics for shoulder arthroplasty, there's sort of 3 options, which I'm sure everyone's familiar with. One is general anesthesia alone, which is convenient because you can induce an anesthetic usually pretty quickly. It provides assured intraoperative amnesia and akinesis, and it's easily prolonged and then easily reversed, to suit surgical needs. Downsides of general anesthetic are, of course, standard things like nausea, vomiting, hoarseness from intratracheal intubation, and potentially inadequate postoperative analgesia. Now, regional alone, and from this, what I mean to say is that there are some centers that, relatively few, that might allow for arthroplasties to perform specifically, just under a regional block, perhaps with a very, very minimal sedation. And in this case, there's the potential to completely avoid airway management, and it certainly assures postoperative analgesia if you're able to perform the surgery under the block alone. Then definitely, at least for a little while after the surgery, patient's pain will be well relieved. Downsides to this are it requires a very agreeable patient, a very agreeable surgeon, and proficiency, obviously, in the regional technique. There's also, of course, risk of failure and standard block-related complications like risk of neural injury. And if there is a problem, particularly in the middle of the surgery, there's limited access to an unsecured airway that's positioned sort of far away from you, often covered by drapes in the sitting position. There's a propensity matched cohort looking at 4,000 people. I believe it was a few hundred of whom had undergone their arthroplasty just under a regional block. This was at a specialty. This was at a specialty orthopedic center in New York. And they found that patients who had undergone their arthroplasty just under regional were more likely to be discharged home, had lower in total in-hospital complications, and had reduced rates of hospital readmission. Now, you can argue, and I think it would be a very fair argument, that there would definitely be a degree of patient selection in terms of those who would be able to tolerate having arthroplasty done just under regional, but still, it's interesting data. And finally, probably a combination of general anesthetic and regional anesthesia, where block is provided as a complement for postoperative analgesia, and then a general anesthetic is provided for the duration of the surgery. That's probably the most common, and that's what we would be typically doing at my center over here in London, Ontario. So I'll start with talking about a little bit more about regional blocks, and I'll start with talking about the potential bad things that can happen with regional blocks, because I want to end on the good note, since I'm a regionalist, and I also think that there's some value to them, and hopefully I'll be able to convince you, everyone here, that there is as well. One of the bad things of regional blocks, that takes a bit of time to perform, and if you don't have a dedicated block room, and patients don't, sort of get into the hospital earlier on, so that so that they can be performed before the surgery, that might be cutting into the surgical time, and that might be a difficult sell to the surgeons you're working with, depending on what they perceive as the value of blocks. Blocks do have risk associated with them. So the biggest one is probably peripheral nerve injury, but there's also other things that could certainly occur. The block might fail. You might inject into the bloodstream, all sorts of things like that. And the typical one that we use here is an interscalene block. So you get some very interesting and unique complications, like potential for things like Horner syndrome or intrathecal injection even. So depending on who's doing the block and the patient, there could be an inconsistency of block effect. Obviously, people tend to get better at things they do often, but even in skilled hands, from time to time, blocks still fail. The other thing is that there's a limited analgesic duration of single shot blocks. It'll rarely get longer than 18 hours, even if you're using, various interesting adjuncts, most of which haven't received regulatory approval. There is the potential for prolonged analgesia with something called liposomal bupivacaine, but most of the studies examining liposomal bupivacaine have had mixed results, and many of the most positive studies have had industry sponsorship, which can which might cause some people some concern. And you could obviate this limited analgesic duration by placing a catheter, but we know that there is an increased rate of complications with catheter placement. There's the chance of secondary failure, which is that the initial single shot block through a needle will work, but that the catheter-based infusion for post-operative prolonged analgesia doesn't work, and that could be because the catheter might migrate, or it was initially just not placed in the right spot. Excuse me. And some institutions might not have an acute pain service or service to actually follow patients who have had a catheter placed. All right, so is there any good stuff about regional blocks? I'd say there's quite a bit of good stuff. One is that nerve blocks reduce opioid consumption, specifically in shoulder arthroplasty. This was a large retrospective cohort, the vast bulk of which, about 95,000, were inpatients, about 3,000 or so were outpatients. People took fewer more opioids, and because of that, they likely suffered fewer opioid-related adverse effects. There was a relatively small, about 300 case series that looked at patients who have had a shoulder arthroplasty and looked at their outcome 2 years afterwards. And in this small series, those patients who had the highest pain scores immediately post-operatively were actually most likely to have poorest function 2 years out. And so this is mostly this is one of the things I'm basing it on when I say that if you have less pain, at least immediately post-operatively, you might actually do better, even in the long term. And finally, Most people are using ultrasound these days to perform these nerve blocks. Now, ultrasound isn't the be all end all, but it does really reduce some block related complications, including local anesthetic systemic toxicity, because we're usually looking at the spread of injectate and ensuring that we're not injecting directly into a blood vessel, which is nice. It also allows more precise perineural catheter placement and verification of that catheter position. If you inject through the catheter and you can see your C5 or you see nerve roots, or you can see your superior trunk moving after injection of the injection through the catheter, you can be a bit more assured that the catheter is going to be in the right spot, or two, that the catheter's based infusion is going to be more effective. And finally, as a component of the anesthetic for shoulder arthroplasty, regional blocks have been shown. This is all-comer regional blocks, including both single shot and catheter-based techniques, have been shown to reduce ICU transfers, hospital length of stay, and various complications. And this is retrospective data from over 60,000 patients, looking at, I think it was some 60 or so, pulling the electronic medical records from 60 or so hospital systems. These are association studies and case series, but I mean, I think that they provide some evidence that, hey, maybe these blocks might be good things. Maybe it might be worthwhile trying to incorporate them. Question of, should you place a single shot? Should you just do a single shot block, or should you use a catheter-based technique? I don't think that there's much argument that catheter-based techniques improve analgesia on postoperative day one, and they decrease opioid use up to that time. Basically, I say up to postoperative day one because at a lot of places the catheter is placed, and if patients are staying as inpatients, they'll be able to keep the catheter until the day they leave the hospital. Then we stop the infusion and take the catheter out, and then they go home. There are some places that use ambulatory catheters, but my site isn't one of them, so I won't speak too much to that. I haven't seen too many studies on those ambulatory catheters. What I can say is that there's no change in length of stay as compared to single shot versus catheter-based techniques, at least based on these meta-analysis of a few thousand patients. But they do they probably keep patients more comfortable at least for some period of time on the first post-operative day. Functionally, it would probably be mostly dependent on institutional practice and resources. If you're working at a center there that they place catheters routinely, that there's a service to follow up on patients, it might make sense to put a catheter in and to have patients be comfortable for that extra period of time. If you're considering starting a regional program and you're basically wanting to sort of demonstrate, look how useful these blocks could be, it might make more sense just to start with single shot, and then you can sort of get some experience, get some institutional experience, and people can see how patients seem to be doing, and then later on start to maybe experiment in selected patients with seeing, hey, maybe if we put a catheter in, we can keep patients comfortable even longer. Is there value in potentially prolonging a single shot block with liposomal bupivacaine? As I mentioned earlier, there were some concerns about some of the liposomal bupivacaine studies, mostly secondary to industry sponsorship. There's also significant heterogeneity. So people have tried to do systematic reviews and meta-analysis on the liposomal bupivacaine blocks for shoulder surgery, and the problem is these comparisons included sort of single shot blocks with interscaling blocks with the liposomal bupivacaine as compared to local infiltration by the surgeon, other single shot blocks with just standard bupivacaine, or continuous catheter based blocks. It's kind of difficult to be able to piece apart any true effect. All right. So, are there any is there any data reporting in the implementation of ERS protocols for shoulder arthroplasty? A little bit. There's two studies. There's basically two studies or two descriptions, and they're both audits of single institution experiences with the implementation of an ERS pathway. This one institution based their pathway on an already implemented hip and knee arthroplasty protocol. They discussed the stepped implementation, which included those things we talked about earlier, stakeholder meeting, and they drafted a pathway and then heavily selected their patients. They described that patients, amongst other things, needed to be able to, quote unquote, take charge of their own health. Pardon me. And the components included things like patient education, an ambulatory interscaling block catheter, otherwise multimodal analgesia, and postoperative nausea and vomiting prophylaxis, and antifibrinolysis, lysis, which I think was usually tranexamic acid. And then they compared patients in March to July of 1 year to patients in March to July of the next year. And they showed that their length of stay decreased pretty dramatically, actually, almost by half, from 3 days to 1.5 days. There probably was a degree of patient selection here as well, though, since the patients that they included in the arthroplasty in their ERAS protocol needed to meet fairly stringent criteria. The next study included was again an audit of a single institution experience. They compared consecutive patients after implementation to a matched series of consecutive patients who had undergone the surgery in the year prior. And they did exclude certain revision procedures or complex reconstructive patients. They again described their step implementation as 3 plan to study act cycles, and their interventions were focused on preoperative patient education, a standardized anesthetic regimen, entertainingly accepting that their block wasn't standardized, and it's because they couldn't get all of their anesthesiologists to agree on a specific block that they should do for their shoulder patients. But in any case, they then assessed results, but patients still got a block, as we'll describe in the next slide, and they assessed their results based on a couple validated shoulder outcome scores. Of 150 or so patients enrolled, 122 ended up undergoing surgery through the ERAS protocol, and they ended up matching and comparing 71 patients. All of them did receive a regional block of some sort, and they showed that their length of stay, they did it nights in hospital as compared to days in hospital, decreased from 2.4 to 1.9. Their single night stay rate, meaning patients who left the next day, actually increased, so that was good. And their complication rate stayed about the same. There was no change in patient satisfaction. So overall, my conclusions from this, and we can talk about them, there's disagreement, is that ERAS pathways have the potential to decrease patient length of stay, and while still maintaining low rate of complications and high patient satisfaction. And I see that there are, my little chat bubble is increasing in numbers, so maybe there's some questions to talk about. I'll just finish this quickly if I can, and then we can get to the questions afterwards. I just can't see the chat bubble, how my screen is set up here, but feel free to interrupt me if there's something pressing. And then pathway components can be informed by already existing guidelines, and that regional anesthesia probably has some role to play into the perioperative management of acute and post-surgical patients. So what slides are there for shoulder surgery? And this will be very quick. Just to mention briefly that the bulk of shoulder innervation is provided by the suprascapular and axillary nerves. This is from the superior trunk and posterior cord, more distally the posterior cord. There are smaller portions provided by the lateral pectoral, subscapular, and musculocutaneous nerves, and depending on the surgical approach, the territory of the supraclavicular and medial brachial, cutaneous, intercostal brachial nerves might be violated. So here we can see the suprascapular is this sort of orangey one, and that's basically mostly posterior and superior, and the subscapular tends to be more anterior, inferior, and then you have sort of axillary, a bit more laterally, and musculocutaneous, sort of anteriorly, lateral pectoral again, sort of anteriorly. The interscalene brachial plexus block, as we all likely know, is the gold standard for surgical anesthesia and analgesia to the shoulder. It provides comprehensive anesthesia. It does spare the supraclavicular intercostal brachial distribution, so it usually isn't too much of a problem. The goal is to have posterior spread along in the interscalene groove between the anterior and middle scalene muscles. Typical volume would be something like 10 to 50 milliliters of anesthetic. It reliably provides excellent shoulder anesthesia. It also reliably provides excellent hemidiaphragmatic paresis, which is very frustrating because it makes it difficult to use in certain patients, particularly those who have significant respiratory disease. In an effort to get a little bit further from the phrenic nerve and hopefully provide some sort of diaphragmatic sparing, people have experimented with targeting more distal components, including the superior trunk. These pictures are from a report on patients who had undergone shoulder arthroscopy, not arthroplasty. And instead of targeting the nerve roots in the scaling groove, they basically targeted the superior trunk. And they found that these patients did, for their shoulder arthroscopy, did have a general anesthetic. And basically, these investigators compared pain scores in patients who have had either interscaling block or the superior trunk block. And the postoperative pain scores were pretty similar, but they found a much lower rate of diaphragmatic hemiparesis, so 5% instead of 70%, in patients who had the superior trunk block instead of interscaling block. That's still 5% risk is still a risk, however. And so people have suggested, hey, maybe we can go even further if the bulk, of shoulder innervation is provided by the suprascapular and axillary nerves. Maybe we could just block those, and you can. There's a couple of different approaches to the suprascapular nerve. You could do an anterior approach, and people have experimented with various volumes to try to obviate this diaphragmatic hemiparesis. But probably the safest approach, if you're really, really concerned about sparing the phrenic nerve, would be to go posteriorly. So you can anesthetize the suprascapular nerve by injecting anesthetic at the lateral floor of the supraspinous fossa, and you can find that relatively relatively straightforward fashion on ultrasound. Provide about 10-15 milliliters of local anesthetic, and the axillary, not the axillary approach to the brachial plexus block, but the axillary nerve block overlies the posterior surface of the humerus. And this can be found by basically imaging the humerus in long axis, finding an area where the posterior shoulder capsule blurs the ultrasound image of the humeral periosteum. I like to then turn my probe into short axis, because then I can see my needle as it goes towards my target, which is just over the periosteum of the humerus, about 1-2 centimeters below that blurred point. And then you can provide, you can inject anywhere from 5 to 15 milliliters of local anesthetic. If you use less than 10 milliliters, the risk of radial nerve paresis through the quadrangular space is lower. And that is all. So I'm happy to send the slides to whoever might be interested, if anyone has interest, and otherwise ready for some questions. Thanks very much.
Thank you, sir, for your wonderful talk and very, very informative. With your permission, can we take the questions from the chat box, sir?
Ankur, let me congratulate first.
Yes, sir.
It's a tradition. The speaker is from international faculty. Dr. Christopher has done a wonderful job in delivering such a good lecture. And I was very much impressed about the good and the bad. Dr. Christopher, there is a third part, the ugly, the good, the bad, the ugly, because, you know, the developing nation and developed nation has got this gap. Many patients, because ultrasound is not freely available in our nation to everybody, and even in the best of the institutions, you may not be able to get access to the ultrasound guidance blocks because it is marred by some legal implications, by the resource challenge funds of the institutions, and many other factors. And we have seen so many times that the regional blocks, the patients landing a bit to the neuropraxia and the pneumothorax, and so many things are keep on happening. And the intellectual level, that was a very good point. How much the patient cooperates, how much intellectual level the patient has when you are administering a regional block. Now you are just eating up the time of the surgical time there. So you have to have a different room to at least administer the block, so that sometimes it takes time. It's a time-consuming process to at least get a good block, good effect for a shoulder arthroplasty. Because when we are concentrating on the eras, the time factor is a very important part. So it's a very well delivered. And one thing just I want to ask before we can take the questions, how much follow-up you really do for these patients whom you're giving the GA and the regional together, whether you follow them in your own post anesthesia OPD or post pain OPD? Do you have any facilities such type in your institution?
So we have the capability of doing so. We used to do so. But we stopped actually a few years ago. And I don't know exactly why. It's possible that there was there wasn't much interest in doing so. My understanding, because we actually sort of stopped, I think a year or two before I came on as a fellow. It's possible that Dr. Visa might have been involved a little bit, since she was did the regional fellowship a year or two before I did. I think we used to follow up patients who had blocks the next day or two. And my understanding is that usually their block wore off usually sometime over the night or in the next morning. And the ones who had been sort of prepared for that experience tended to do a little bit better. We sort of told people at some point your block's going to wear off. Before you go to sleep, make sure you take some pain medication so you've got something on board before it wears off. I think that we also used to do a home regional program, but again, that sort of fell by the wayside as well. I'm not sure if Dr. Visa is able to maybe articulate
I can
a
add
little more
some
about
to
that.
that as well, Chris. Yes, when I was doing my fellowship, we used to follow up our patients after 24 hours of doing the block. We would do a phone consult. So the advantages of that would be that we would catch the rebound pain, and then we could give them advice on post-operative multimodal analgesia. But the way it ran was that we could not pick up any post-operative neurological complications because it was too early. So we needed that 3 to 7 day time period. And then that kind of follow-up was very difficult to perform. So our source of information of post-operative complications came into the realm of our surgeons. So our surgeons would see their patients 2 weeks post-operatively and as well as after 6 months. So if they did pick up anything during their post-operative consults, they would bring the patients back to us if it was related to nerve block. But we do now do a very good educational program, and we give them quite a bit of information on managing pain after going home after having a block. So we have not as yet seen many complaints about patients with rebound block, and we have a lot of patients coming back asking for a block if they're coming for the other shoulder as well. So that shows that we have been doing a decent job, I suppose.
Yeah. Most of the times, actually, these patients come for some other illness, and then you're really able to follow up. Sometimes their complaints are there still pending. There's some neuropraxia occurring, and sometimes the surgeon may not be able to pick up. So many chronic syndrome also develops in these type of patients. But I think it's very difficult. The story is same everywhere about the follow-up. It's not different. We have to depend upon our surgical colleagues to at least convey the information timely in the right manner so that we can get a follow-up. Dr. Christopher, there are certain questions. I think Dr. Madhuri Gudi, can you unmute yourself and ask the question directly? She asked one question. Dr. Madhuri, or I shall ask on your behalf.
Now all can unmute themselves.
Yeah. Good evening, sir. Good evening, sir.
Good evening, Dr. Madhuri. Please carry on the question, please.
Yeah, my question to Dr. Christopher, that you have compared regional nerve blocks with general anesthesia. So what about the functional outcomes and the quality of life? Is there any study which has examined this comparison between regional blocks and general anesthesia for shoulder arthroplasty? Because nowadays that is very important.
Dr. Christopher, unmute, please. Unmute yourself, please.
I didn't realize I'd been muted again. The studies that I'm familiar with would mostly looked at probably more easily measured outcomes, like oral morphine equivalents. There was that one case series that talked about functional outcomes 2 years afterwards, but that was only 300 patients, and that basically looked at patients who had more versus less pain. In terms of improving quality of life in long duration afterwards, I'm not particularly familiar with anything with any good studies saying that this is definitely better. In terms of doing under nerve blocks, sorry, I misunderstood your question for a second. I thought you were asking, is there a benefit to doing it purely under regional? And I'd say, probably just avoiding a general anesthetic in some patients who, don't tolerate general anesthetic particularly well. But that's not really.
It was mainly about the follow-up only, because these type of data you accumulate during the follow-up studies. The GA combined with a regional and a regional alone, or a GA alone. So those comparative studies are also difficult to analyze in such circumstances till you do the good follow-up, or the patient coming to the anesthesiologist after a regular, a follow-up with them also, apart from the surgeon. I think she's right, but the other question part is the obstacles in the implementation of ERAS in India. I don't think so. Dr. Christopher will be able to answer that question.
We will answer. We can answer that question.
You are correct.
No, no.
I'm sorry.
Yeah, that's true. Because I already told there are so many obstacles, basically coming right from the economical, and then the medical legal, then the educational parts everywhere. You cannot achieve the entire eras in totality in Indian scenario. We are doing it in institutions, but if you go to the practice of entire national practice, it's very difficult to achieve eras in the present circumstances. Developed nations, they have got almost, they are also they face difficulty in the initial part when the eras was started. But now in India, we are doing, I think we are receiving so many of the articles in the journal, which are based on the eras. But still the obstacles are there, the limitations are there. And Dr. Madhuri, you can also develop on one or two factors, apart from which I just pointed out. You can also tell.
Yes, we have so many articles and so many research coming up on ERAS protocol in India in various types of surgeries. So we have been constantly asking ourselves whether ERAS is a myth or a reality for us here. So so many researchers are working on that, and only time will tell us whether it is going to be successful here in India. And to add to this, in India, we have a population which is, especially those coming to government hospitals, the problem of communication with the between the patient and the anesthesiologist or the surgeon, and the problem of patient education and teamwork. All this takes a toll on ERAS management.
Yeah, definitely. This is true, because all the articles we have received in the journal are at least almost pointing to the same thing. But it's a good thing because we are collaborating with now the developed and developing nations. With Canada today we have a webinar, so these points are important for them also to at least know what is really happening in our country. Anybody wants to ask a last question? One question. We have got time for one question only. Anybody wants to ask?
I think Dr. Divitya wanted to make a comment. Dr. Divitya, please.
Yeah, thank you. So Dr. Bajwa, I just wanted to make a
Sorry, sir. I was thinking you are in the conference now. That's why I would have asked you to.
Sorry, very much. I think Naveen spotted me. So the only comment I wanted to make is, as far as ERAS implementation is concerned, it's all depends on how you build your team and how you educate yourselves and your patients and the rest of your team members. And the team members start right from the surgeons down to the surgeons and anesthesiologists, of course, but you also need to include your technicians, your ward boys, your nursing staff, your physiotherapists, your dietitians. And it takes a hell of a lot of effort to sort of do it. But if you're able to get your team together, it is doable even in our circumstances. India is very heterogeneous, so I'm sure you'll have some centers where it has been done. Like in our center, we've been able to do it for many specialties. And there are challenges of course, all over the place, and communication between team members is actually one of the stumbling blocks. If we can all learn to speak to each other and learn from each other, I think we will be able to implement at least most elements of ERAS in many more situations. That's the only comment I wanted to make.
Thank you, sir, for your nice comments about that. In fact, it's a reality. The challenges will remain, but it's always the team effort which can at least able to help us in building the ERAS team. I think our moderators, the Dr. Nishant, Dr. Ankur, I think this is a good enough time. This is 7:35. We should move to the next speaker, please.
Yes, sir.
Dr. Ankur, please.
Yeah, thank you, sir, for the wonderful and informative session and generating a good discussion. We now move on to our third speaker. The third speaker will be introduced by Dr. Nishant. Over to you, Dr. Nishant.
Our next speaker is Dr. Deepti Visa. She is a faculty in the Western University of London in Canada. She has various degrees, the MBBS, DNB, MSc in measurements and methods. She is, as I mentioned, a faculty in the Department of Anesthesia and Perioperative Medicine at Western University, London in Ontario. She has had a strong connection with Hyderabad in India, after which she went to the UK. And then she has done various fellowships in Canada. the General Anesthesia Fellowship, the Clinical Fellow in Quality Improvement, Clinical Fellowship in Regional Anesthesia also. She has won multiple awards in various conferences. She has attended multiple workshops, CMEs and conferences. She has multiple publications in index journals and is very interested in research, teaching and academics. Besides, she is very passionate about sports. I believe she was the captain of a school cricket team. She has interest in crochet, and a good thing, she's a food lover too. A very warm welcome, ma'am. And over to you for the interesting talk, regional anesthesia for hip surgeries. You need to unmute yourself, ma'am.
Okay, are you able to see my screen?
Not yet.
Okay, start broadcast. Okay.
Yeah, something is coming.
Hold on. Okay. Is that visible now, please?
Yeah, fine, ma'am, fine. Please.
Thank you so much. I would like to thank the panel, the president, Dr. Bhimeshwar, and esteemed members of ISA India for giving me the opportunity to come in the morning today here and have this lovely academic discussion with such wide range of Indian anesthesiologists today. So it's quite an humbling experience to be a postgraduate student in one of the conferences to be able to come up and speak today. It is a little unnerving, but and also quite a humbling experience. Thank you so much. I'm not very sure if Dr. Bhimeshwar remembers, but again, as I said, my attachment with Hyderabad, I actually did a 2-week ophthalmology rotation through NIMS at Sarojini Devi Eye Institute in Hyderabad, where Dr. Bhimeshwar was the head of the department. And I'm sure he doesn't remember me, but I was there with him then. So we will be talking about regional anesthesia for hip surgery today. And I would like to make it a little clear here. I would be talking more about peripheral nerve blocks for hip surgery rather than going into the discussion of general anesthesia versus regional anesthesia for hip surgery. So today's topic will be mostly concentrated on peripheral nerve blocks for hip surgery. And what we will be going through is to review the nerve supply of the hip joint. We'll be discussing recent evidence for doing a peripheral nerve block for hip surgery. And we will enumerate the commonly performed blocks in our institution. So we'll go from what are we actually doing. So nerve supply of hip joint, like most of the joints, follows the Hilton's law. What is that? It is that the nerve that supplies the muscles crossing a joint also supplies articular branches to the joint and also the skin overlying the muscle. So the main nerve supply comes from the lumbosacral plexus, as we all know. And the 3 major nerves that supply the anterior capsule and the bone and the muscular attachments are femoral nerve, obturator nerve, and the accessory obturator nerve. All of them originate from the lumbar plexus, follow down around the psoas major muscle, the femoral and obturator nerve lying between the anterior and posterior portions of the psoas major to enter deep to the inguinal ligament and fascia iliaca to lie beside the femoral artery, the femoral nerve. So the obturator nerve also comes more medially around the psoas major muscle and gives off articular branches before dividing into its anterior and posterior divisions. And axillary obturator nerve becomes quite interested. People have become quite interested in it in the last 4 years because of its involvement with our PENG block. So it is present in about 10 to 30% of the patients. And it gives off articular branches to the anterior capsule, more often the medial, the superior medial and superior lateral part of the anterior capsule. Posteriorly, the innervation comes from majorly the sciatic nerve. So the superior gluteal nerve, inferior gluteal nerve, and the nerve to the quadratus femoris give off articular branches to the hip joint as well. So this is the sensory innervation and the osseous innervation. I think we all know about these innervations, so I would not go deep into them. What is interesting here is the systematic review and meta-analysis done by Tomlinson et al., which was recently published in 2021, looking at the consensus on the innervation of the anterior and the posterior capsule of the hip joint. So anteriorly, femoral nerve, obturator nerve to most content, and accessory obturator nerve, as we previously discussed, give good amount of articular branches to the hip joint. Posteriorly, the posterior capsule gives off with twigs from the sciatic nerve, the articular branches. Nerve to the quadratus femoris, also as you see about the darkening of the areas, gives off quite a bit of innervation to the posterior capsule. Now, sorry about that noise, I'm still in the hospital.
Code stroke, emerge department, zone E, level 1, now. Attention all staff, code stroke, emerge department, zone E, level 1, now. Attention all staff, code stroke, emerge department, zone E, level 1, now.
Sorry about that. What is important to note here is the innervation of the capsule with mechanoreceptors and nociceptors. So from this little table, what we see is the shaded areas. The red and the brown show the density of mechano and nociceptors in the anterior capsule more than the posterior capsule. So this was actually highlighted in one of the cadaveric studies and clinical studies done recently. So our bang for buck is to block the anterior, use blocks to anteriorly rather than anything posterior. So what is the evidence of doing a peripheral nerve block for hip surgery? We'll mainly concentrate on two types of surgery. One is the arthroplasty, and the next one is the most commonly performed, which is the hip fractures. Total hip arthroplasty, this was a systematic review and meta-analysis published in 2021 in regional anesthesia and pain medicine. It involved 57 collaborators from 10 different countries. They looked at 122 studies involving more than 1 million patients. 82 randomized controlled trials were involved, 40 observational studies. And then what they found was that the odds of having respiratory failure after a peripheral nerve block, here they included peripheral nerve block as in femoral nerve block. They did lumbar plexus block, fascia iliaca block, 3-in-1 block, all were included as a peripheral nerve block. So any of the block had odds of reducing respiratory failure. Also found that the odds of having delirium with block versus no block also was less. This was with high quality evidence, and they had high quality evidence for reduction in surgical site infection as well. They did have other decrease in odds of having other complications, but not to the same level. So there was more moderate to low evidence for decrease in cardiac complications and decrease in venous thromboembolism. What it did not show is any mortality benefit. So they came to a conclusion that the level of evidence is moderate, but they strongly recommend doing a peripheral nerve block for a hip arthroplasty. Next, and this is a group from Europe which does procedure-specific guidelines. So they did a systematic review for just hip arthroplasties published in Anesthesia in 2021. They looked at all the studies with peripheral nerve block from July of 2010 to 2019. This included 108 randomized controlled trials, 21 meta-analysis, and they concluded that femoral nerve block and lumbar plexus block had procedure-specific evidence of reducing pain and other outcomes. But for these procedures, the side effects, especially with motor nerve block and with lumbar plexus block, it is the deep block and difficulty in performance of the block that they would not recommend it. And they do not find very much of evidence for just sole lateral femoral cutaneous nerve block. The anterior quadratus lumborum block that they included had only a couple of randomized controlled trials until 2019. So the evidence is still emerging on that. So they did have grade D recommendation of a single shot fascia iliaca block or local infiltration analgesia. So we do follow this, and for us in our institute, we perform local infiltration of analgesia along with multimodal analgesia going by the Prospect guidelines. What is the evidence in hip fracture? This was a recently updated systematic review by Gui et al. And published in 2021 again. And this involved 49 trials, more than 3,000 patients, looking at evidence until 2020 with block versus no block or a sham block for hip fractures. And what they found was the benefit on pain at movement after a block placement, which are good high quality evidence, and decrease in acute confusional state with reduction of risk ratio 0.67. Reduction in chest infections, again, moderate evidence, and time to first mobilization also had moderate evidence. So on the whole, there is benefit of doing a nerve block. So coming to what we do at our institution, as I just informed, for total hip arthroplasties, we perform local infiltration by the surgeon with a mixture of ropivacaine, ketorolac, and morphine. Now we have moved over to mostly plain ropivacaine as well, and Dr. Hansabout can add on to that, along with multimodal analgesia. So they receive preoperative acetaminophen or paracetamol, along with COX-2 inhibitor, or and then we follow them up postoperatively as well. So now with the latest crunch in healthcare services in Canada, we are moving towards discharging our patients earlier. And then we have been successful in discharging about 10% of our hip joint arthroplasties, to be honest, on day one after surgery. So this becomes quite challenging to perform nerve block in these patients. So we don't want any motor weakness. We want them to get up and do their physio before going home, be enabled to mobilize themselves at home with having their pain controlled. So we use quite a bit of multimodal analgesia with breakthrough opioid analgesics and found quite good results. And we do follow them up remotely after going home. The most of the nerve blocks that we do in our institute are mostly for hip fractures. The most common one we do is femoral nerve block. And we teach our residents quite early in their residency about a femoral nerve block. We also have been involved in teaching our emergency physicians in performing femoral nerve block and fascia iliaca block, so that on arrival in ambulance with a hip fracture, they're able to perform the block first thing in emergency room. We also have enabled our residents to follow up on the block after they go to a room 12 hours or 15 hours after they arrive to the hospital before their surgery. And if not, if they come to surgery before that, we again repeat a block before surgery. So this has been inconsistent, to be honest, because of resources and other factors. But this is what we commonly do in our institute. With the femoral nerve block, there is umpteen amount of information as to how to perform a block and what to do and what are you looking at. So I won't go into details of that, but I will give you a couple of tips and tricks that we use to optimize our needling and our positioning, especially with morbid obese patients. The pannus usually comes in the way in the groin when you're putting your probe. So what you could do is pull the pannus up if you have an assistant to hold the pannus up, or to use the thick tape to tape the pannus to the bed. That will bring it out and then make it easy to scan for the femoral nerve. And what is also interesting with the femoral nerve is that you don't have to be very close to the nerve. Being just under the fascia iliaca, lateral to the nerve, and not aiming for a circumferential spread of the drug also gives you a beautiful block. And also what we all need to bear in mind here is where you're doing the block. So if you see that you see a femoral artery and the profunda femoris, that means you're quite distal and you need to move proximal to have a single femoral artery. The reason behind it is that the articular branches from the femoral nerve come off from the main trunk as well as from the muscular branches of the femoral nerve. So the femoral nerve divides into its anterior and posterior divisions very early on. So to do it as proximal as possible is the key here. I think somebody needs to mute their
Dr. Dipti, you unmute yourself now. Unmute yourself, please. Dr. Dipti, unmute yourself.
Yeah. All right. Okay, so one thing also you need to be cognizant of is that these patients with hip fractures, using nerve stimulation, you have to be quite vigilant that you don't want to cause a lot of muscular movement with your nerve stimulation so that it will increase their pain while you're doing the block. So we do not do nerve stimulation while we are using the femoral nerve block for hip fractures. We do it just under ultrasound guidance. Usually 15 to 20 ml of 0.25% or 0.5% ropivacaine is what we commonly use here for these patients. The blocks usually give us good analgesia for about 12 to 16 hours. So what are the good parts of this? We already did a little bit of talk before the evidence. So you do have a benefit of pain, especially with positioning of the patient and movement after 30 minutes of doing a block. There is an opioid sparing effect that has been shown in a couple of RCTs. The time to first mobilization, although the quality of evidence is moderate to low, but there is some evidence for that. Delirium, it is picking up. It is a low to moderate evidence of decrease in delirium with femoral nerve block, but still it is positive. Why we don't do it for our hip arthroplasties? It does come with motor weakness. But for our hip fracture patients who do not get mobilized until more than 24 hours after surgery, this is a very good option for us. And also is that the motor weakness stays about 25% even after about 8 to 10 hours after performing the block. So well, that is one of the reasons we don't do it for our hip arthroplasty patients. Coming to fascia iliaca compartment block, again, one of the most commonly performed blocks on the hip. And two methods described, the infrainguinal and the suprainguinal fascia iliaca compartment blocks. Our emergency physicians are well trained in performing infrainguinal fascia iliaca compartment block. Here you will see that the needle is inserted little medial to the medial margin of the sartorius, just below the fascia iliaca over the iliopsoas muscle. Again, plain block, it needs volume, low concentration, especially when you have thin, frail, old patients with renal failure. You have to be mindful of how much you're putting and what is the concentration. Even about 0.2% gives good analgesia. And volume is usually about 30 to 40 cc's that the ED90 in a couple of studies has shown to be about 23.6 mils. We usually perform about 30 to 40 cc's of local anesthetic with our blocks. Coming to suprainguinal fascia iliaca block, again, two areas where it has been blocked has been described. One by Hebbard, which is the top one, which is the bow tie sign. where you have the oblique placement of your probe, and you'll see the superiorly the internal oblique muscle, sartorius, and the fascia iliaca covering the iliacus muscle. And then you unzip the fascia between the fascia iliaca, and you see a very beautiful spread. And 100% of the times you see your femoral nerve getting absolutely drenched with your local anesthetic. The other method of doing a suprainguinal block has been described by Hebart, and the other one was Dr. Desmet. And they put their probe transversely over the anterior superior iliac spine, looking at the iliacus muscle and the fascia iliaca lying on top of it. Here you have to be mindful of the deep circumflex artery, which is present just above the fascia iliaca, and fascia iliaca block on just here as well gives you a very good spread. So again, what are the advantages of doing this block? Pain with on movement after 30 minutes. Again, there are a couple of RCTs that have shown the benefit. Opioid sparing effect has been shown in a few RCTs as well. Decrease in odds of having delirium and post block with no block has been shown. Improved patient positioning has been shown, but it is a low quality evidence. But clinically, personally, I have been using this block mainly for these reasons. Immediately after doing a block, we position the patient within about 5 to 10 minutes, and there is drastic benefit in that. A patient who is screeching in pain just on touching the hip will be able to turn onto their side, or sometimes we are able to even sit up the patients after performing the block. Hospital length of stay is decreased by about 1.2 days, which I remember in a couple of RCTs. So that is also beneficial, especially in bed crunch situation that we are currently in countries like with social medicine. We do not perform this block more in our hip arthroplasty patients for the reason being motor weakness, and also that we are mobilizing our patients quite early. These days, they leave the hospital within about 36 hours after having a hip arthroplasty. So if at all in your institute, you have patients who stay back for more than 2 or 3 days, this is still a very good option to have. Coming to the latest star in this area, the pericapsular nerve group block, or the PENG block. First described by Giron Arango and Dr. Philip Peng from Toronto. This one blocks the articular branches of the femoral nerve and the accessory obturator nerve. So where is it performed? Using a curvilinear probe. It uses to scan the anterior inferior iliac spine, coming close to the iliopubic eminence, looking at the psoas tendon and infiltrating behind the iliopsoas tendon. Lot of studies. So from the inception of the idea in 2018 to 2022, so 4 years, and there have been more than 300 publications on the block. And to the extent that people have already started doing systematic reviews and meta-analysis as well. This one published only last month, low quality, not yet, with 37 patients, showing quite promising results favoring the PENG group. Why is it being favored? One of the big reasons is no motor block. It is one of the selling point of this block is motor sparing. It decreases the time to first walk as well. So mobilization is quite early. Will I be doing it for all my hip arthroplasties in the future? Coming to a couple of RCTs that were done, they have found that when compared to femoral nerve block, they had about quadriceps strength intact in 60%, which means that 40% of the patients still had quadratus weakness. So that is quite a bit of, quite high in my opinion. And then, but then it wears off quite quickly as well. So within about on day one, they have 90% of quadratus strength back when compared to femoral nerve block, which is only about 50%. Same thing, another randomized control trial has shown that 77% the quadrator strength was intact, meaning 23% of the patients still had quadrator's weakness. So the quadrator's muscle weakness has been noted in about 20 to 40% of the times. So is it low enough for me to perform on every single patient of hip arthroplasty? Not yet. I will be waiting. There have been more than 5 or 6 randomized control trials just published in the last 6 months. So I will be watching this space. I will be waiting for a little more evidence before. So some of the arguments for the quadrator's weakness have been the volume. So the original authors had described 20 cc's of local anesthetic injected. So with this, they have good spread over the articular branches, but with performance in so many different areas and so many different countries, we're coming to know that there might be some spread towards the articular branches or the muscular branches of the femoral nerve, causing the femoral quadriceps weakness. So we have to be watching this space a little more time before we can start using it as a standard of practice. So I would like to pick your brains on this. I'm sure everybody has not slept by now. If not, I have a little brain picker for you, just to know what kind of practice you usually do. So if you have a case, say about 92-year-old, demented old granny that you normally see for a fracture neck of femur, take into consideration, and she probably has her weight is about 45 kilos. She slipped and fell about 12 hours ago, now has an intertrochanteric fracture of neck of femur. She's diabetic, typical atrial fibrillation on rivaroxaban. She took about 24 hours ago. She has normal kidney function, which is good, and moderate aortic stenosis. So she's coming for a dynamic hip screw in the next couple of hours. So what would your anesthetic management be? You could scan this code and you'll be prompted to a quiz. So, and I will be looking for your answers, and I'll give you a couple of minutes for that, and then we can proceed for questions. Give me one
So all the
second.
audience members are encouraged to scan the QR code, right?
Yes, please.
Do you have any slide after that, Dr. Dipti?
No, I'm done actually.
Okay, then
Thank you.
give them 1 minute at least.
Sure, absolutely. Take your time. I'm figuring out how to go check for my results. I
It's
have the
looking
screen
for a
ready to
Microsoft sign-in.
Oh, it's asking
Yes.
for a sign-in, is it? Oh, bummer.
Yeah,
Okay.
it's asking.
Oh, bummer. Give me one
Sorry, it actually
second.
said I don't have permission to view the form.
So QR code,
Oh.
we are not able to get it.
Okay, 1 second. I'm going to figure it out. Sorry about that. So I think I did my settings are quite. All right. So, okay. You can actually voice your opinions if that's okay. So let me see what the options I have given. Okay. 1 second. Let me go to my Microsoft Forms. I'm going to stop sharing my screen for a second. Give me 1 second. Sorry about that.
Dr. Dipti, you just give 4 choices. We will take one.
Yes. So, okay. Yeah. 4 choices. General anesthesia with a peripheral nerve block. Spinal with a peripheral nerve block. Only spinal, only general, or nothing.
What about epidural?
No.
What about epidural?
Epidural.
Please,
Yeah,
please,
neuraxial. Let's go neuraxial.
please repeat question again, na, ma'am.
Okay, so let me put the question again on the screen. I'm sharing the screen again. Start broadcast. Okay. And we'll go back to that slide. Okay. Can you see the slide now?
Yeah.
Yes, visible.
Yeah. Okay. That's your
One is
patient.
visible.
How would you anesthetize?
Mainly for the IT fracture of intertrochanteric fracture neck of femur, coming for
Yes.
dynamic hip fluid.
Yeah.
And the catching part here is atrial fibrillation on rivaroxaban.
Yes.
Better to go for regional anesthesia. That one block.
Yes. Okay. Thank you so much. Any more opinions? Any more?
I'd probably do a block and then give a general anesthetic. I'd feel uncomfortable putting a needle into the neuraxis given her anticoagulation.
There are certain responses in the chat box, ma'am.
Oh, thank you.
Dr.
Ma'am?
Thippe Swami.
GA with PNB. Okay. Okay. I need to catch up on this.
Dr. Prashant believes low dose spinal with PENG.
Okay.
Mahadevi, Dr. Mahadevi, GA with PNB.
Beautiful.
Dr. Naresh Paliwal, sir, FICB followed by low dose spinal with isobaric levobubivacaine.
Okay.
I will go for a graded epidural.
Epidural with rivaroxaban.
Graded.
So if you want to put a needle in the back with rivaroxaban on
Rivaroxaban.
board.
I don't have to monitor the INR and PTI for rivaroxaban, patient on rivaroxaban. Oral anticoagulants, we have oral anticoagulants, and best part is either it's an apixaban, rivaroxaban, or dabigatran. You can't measure the INR and PTI.
Yes. Yes.
So
yes.
But the patient, surgeon is doing the surgery also. That's the most distressing part. You are afraid of epidural hematoma. And what about the surgeon taking participation in the surgery? Post-operative, you can have so much hematoma in the surgical field also.
Very, very important. So the reason I put the 24 hours is because of discrepancy in the guidelines between North America and UK. So that is the reason I gave the catch of 24 hours. There was a reason to that. So as the guidelines for oral anticoagulants has 3 to 5 days. With normal renal functions, they ask you to wait 72 hours before performing a central neuraxial blockade. But Europe and UK have been quite progressive with performing central neuraxial blockade. And then they have their own practice guidelines. They have not been nice recommendations yet. So not supported with, so they are going with risk and benefit analysis. And they do support after 24 hours performing a central neuraxial blockade. So that was the reason I put the 24 hours there.
We wrote this article with the North Americans I'm talking about. We wrote in 2012, almost 10 years back, the role of the neuro-oral anticoagulants. That's why I said 24 hours is a good catching point. You can go for the neuraxial blockade.
Okay.
That's why.
So we personally had one of our incidents. So I did a little bit of a literature review about 4 years ago. And incidentally, about the last 10 years, all the epidural hematomas that were reported were from apixaban. So oral anticoagulants are not as nascent as they are projected to be. No monitoring, easy to easy compliance and everything. But for regional anesthesiologists, they give me a little bit of a scare when patients with, especially that age group, I'm still very conservative.
And what is your choice in this ultimate choice of yours?
Oh, my thing would be exactly as Dr. Hansabout had put in, peripheral nerve block first, and then go for a general anesthetic.
Well taken. That's a good lecture, and really discussion part is always good. And the best, just a minute, ma'am, you are talking about the PENG block. No? PENG block. Many of the RCTs are coming now for the publication. Even we are receiving in our IJ also. So many publications are coming. The best part in that is the quadriceps weakness, basically post-operative. It doesn't depend upon the block, only the volume or the concentration or inadvertent injection into the nerves. It's about how much chronicity of the disease was, how the patients were using their muscle, their musculature, how much it was functioning pre-surgery, for how long. That is very important. The atrophy of the muscles, those factors also have to be taken into consideration, rather than just we are labeling it to the block effect that is causing the weakness. So I think many of the people, they are just walking with the, that either with the stick, and the weakness is there. There are no exercises. There is no physiotherapy. So many times we just land up with the weakness and we are ascribing it to the block, but that's not so. So that factor has to be taken care of when you are doing the inclusion and exclusion criteria for those weakness studies.
I can't agree more to that. It is absolutely right. And especially for also the type of surgery that they're performing. So we have a couple of different arthroplasties that we perform. One is the lateral arthroplasty, posterior laterally, when they enter into the capsule. And now we have what is becoming very popular here is the direct anterior approach to the capsule. So again, for us, one of the things is a limiting factor is the first thing, if a patient complains of weakness in the first 6 or 10 hours after performing the surgery, the first blame comes to anesthesia. So that is why we become quite defensive in our practice, at least in this part of the world. Where and also I think I'm not very sure how difficult it is to get patients out of the hospital in India currently, but it has become quite a challenge for us here that we do not have many elective bed situations. So we have to be very proactive in getting these people mobilized very early and discharged from the hospital. So that is becoming a big onus on us with the backlog of surgeries. So we are looking for options to optimize our hospital stay.
Yeah. Dr. Rakesh, are you there? Dr. Rakesh Garg?
Yes, sir. I am very well there, sir.
Yeah.
I think
give your input.
very nice session. And
sir, I have one question because I am just doing meta and question is.
Let Dr. Rakesh speak first, and you will ask the question.
Thank you, Dr. Bajwa. Thank you, Dr. Bajwa. Only one query I just need to ask from Dr. Dipti. Nice session. Sometimes these patients do come into the emergency, and number of these blocks are given for acute pain relief while they are being undergoing for radiological imaging before they are posted into the operating room. And the emergency physician and pain physician are giving block in the red areas or while they are being worked up. So we were discussing the anesthetic management, but I think these blocks are one of the good options to provide immediate pain relief, like for this 92-year-old female patient who was posted for this type of fracture. So Dr. Dipti, your suggestions, your ideas that how can we provide this immediate relief? Because in these patients, if they go with pain for imaging, for x-rays, they may not cooperate well. One. Second, they have acute response to the painful stimulus. They can manifest various cardiovascular system. So what type of these blocks can be used in a setup, in the emergency setup?
Excellent question, Dr. Garg. And I think I'm not very sure how much of education happens with emergency physicians and casualty doctors, but femoral nerve block and with the use of focus now being quite wide. So educating emergency physicians or even anesthesia residents, if they're able to go to emergency room to perform a block, both fascia iliaca block or a femoral block are very easy to teach. And they come with very low side effects. You can standardize the amount of concentration, you can standardize with weights and then the volume. And then a lot of quality improvement projects have been done. Mostly they come from UK, where they have a standardized protocol for having a nerve block on arrival to hospital. And then about 4 years ago in a European conference, one of the ideas that were presented is from Belgium, where the paramedics were trained to do fascia iliaca block blindly. So that was the initial evidence. And then they would do the block on actually picking a patient up from their home. So whenever they find them lying wherever they are, when the ambulance paramedics would do, first put the block in, then transfer the patient onto the stretcher, into the ambulance, into the hospital. So what they have noticed is quite decreased. They do not give them any morphine during transfer in the ambulance. They don't get any pain medications throughout. So their chances of having acute confusional state is very low. They have seen that they had in their study about 2 days of less hospital length of stay as well. So yes, they have been doing these blocks on arrival and even actually pre-hospital too.
Dr. J will be asking one question, and after that, take few from the chat box also. There are many questions in the chat box. Just see which one you can answer. Jay, you ask your question first.
Yeah. Thank you, ma'am. It was very interesting session. And ma'am, I would like to ask that whether if you will compare paying block, suprainguinal FICV block and infrainguinal FICV block, which one will be better?
So I think it'll be like comparing apples to oranges at the moment, at least, right? So PENG, you have to give some time for PENG to develop. So suprainguinal and infrainguinal have been there for more than a couple of decades. They have good amount of evidence for themselves. But for PENG, it is a very recent block. So that is where I would probably suggest is to wait, give PENG a little more time. It is quite promising. We have been doing it not so infrequently in our hospital, but I personally would wait to compare them right now. So the evidence is just emerging. Yes, please.
Ma'am, there are 8 literature.
Yes.
I remember the name of Hua Choi, and 3 from India. One published in IJ also, Dr. Ashok Jarden. So if you will compare that this block, PENG versus FICB block, so 3 literature is saying that PENG is better, 2 is contradictory, and 2 is saying that FICB is better. So I just registered one meta-analysis. I have the data just in front of my in my mobile. If you will compare that meta-analysis of that randomized control trial, because last month just FIRAG published, but that was not from randomized RCT. That was from observational retrospective also. So a test study is still existing, and so that's why I would like to ask whether in your clinical experience, which one will be better?
So again, it comes down to what you want from your patient. So do you want them to move after 6 hours after you do your surgery? Or are you getting them mobile after 24 hours of surgery? If I have my patient, if it is my grandmother that is having it for a hip fracture, I would do, at the moment with the current evidence, I would do a suprainguinal fascia iliaca block, because if I know that she's not going to be moving in the next 24 hours, that would something be optional for me. PENG block, again, I will be waiting. If I have to do it for a hip arthroplasty, if I can be okay with the patient not moving 20% of the times and not going home the same day, I would still go ahead and do it.
Even time to first rescue analgesia and post-operative morphine consumption, if you will see, look at that forest plot, it was also non-significant.
Mm-hmm. Absolutely, they're not very significant. Yes.
We'll see that.
Yes.
Yeah. Thank you,
So
Dr.
that's
J.
right. You can pick and choose your.
Ma'am, we have to take 1 or 2 more questions there in chat box. Nishant, kindly proceed with the question in the chat box.
Would you mind? Yeah.
Ma'am, there's a comment and a question by Dr. Madhuri Kodi.
Okay.
Ma'am, the suprainguinal fascia iliaca compartment block is useful for hip surgeries in the LA, and to add safety to the efficacy and early recovery, what would be the minimum effective LA volume that you would advise for this block, suprainguinal fascia iliaca?
Absolutely. So a couple of studies have done, and then what they found is the effective volume 90 in 95. So in 95% of the patients was about 23.6 cc's. So we perform about 30 to 40 cc's of 0.25% ropivacaine. So you can use 0.25% bupivacaine as well, or levobupivacaine if you have. We don't have levobupivacaine here in Canada, but ropivacaine is something that we use very commonly here.
Right. And ma'am, for that 90-year-old lady, your choice was a peripheral nerve block. Which one, ma'am?
I would do a suprainguinal fascia iliaca block. Because for me, it is the positioning for the surgery and moving her across, and both of them might work okay. Even PENG block, if I'm thinking she's nice and frail, the bony markings would be very clear. You might as well. And then the emerging evidence for PENG block is the ability to move after 30 minutes of providing block. It is also emerging right now. So you could pick that up as well. But as a standard block that has been there for more than 2 decades, I would pick a suprainguinal fascia iliaca block.
There's another query by Dr. Mayank Dharod. He wants to know whether the increased VAS after hip fracture is only whether it is only due to the fracture or also due to some muscle spasm.
So that's a good question. I don't think I have the expertise to answer that. It will probably be an orthopedician to understand. But having said that, going by Hilton's law, if you are moving the muscles and you're cutting the muscles, obviously you will be having the nerve pain along with the muscular pain as well. So, and the nerve block should actually catch a few of the muscular branches. So, I mean, theoretically, it would seem that it should work, but again, clinically, it is a complete different ballgame, right?
Yeah. So,
there are one or two
yes,
more.
and he does say that Peng is motor sparing. So again, I would like to argue with that. At least a couple of RCTs that have come in have shown that they still have some quadriceps weakness with Peng. And we have been noticing that as well, clinically here as well.
Dr. Partha Sarthi has given one comment, ma'am. He's our associate editor in IJA. Is the more mechanoreceptors in the posterior while more nociceptors in the anterior. That's why femoral and obturator works.
Yes, absolutely. And that is where I was going with it. Thank you so much for highlighting that.
I don't. Any other? Nishant, just see, is there any more question left?
Just another one by Dr. Muthukumar. This is, I believe, is regarding the deep peripheral nerve blocks, whether that will be contraindicated in this patient with the rivaroxaban.
Yes, going by ASRA guidelines, because if you're going for a lumbar plexus block or a psoas compartment block, where the compressibility of the blood vessels would not be possible, you have to still follow the guidelines for a central neuraxial block, which again would be quite conservative.
Correct, ma'am. And I think Peng is also a deep peripheral nerve block. Peng is also considered a deep PNB.
Yes, but there is, again, your femoral nerve is femoral artery is compressible. It's easily there.
Yeah, quite a good session. Nishant, I think we have asked enough questions now.
Yes,
we
sir.
should make ma'am free little bit now. And we should proceed with the rest of the, whatever you call the felicitation and the closing ceremony.
Thank you so much for having us.
Naveen, sir.
Yeah, it was really a pleasure having all of you, Dr. Shalini, Dr. Christopher, and Dr. Deepti. And I must thank all the dignitaries, Dr. M.V. Vimeshwar, Dr. Venkat Giri, Dr. Mahesh Sinha, Dr. Jagit Divetia, dear Dr. Bajwa and Manoj, Dr. Rakesh, and the class coordinators, Dr. Nishant, Monica, and Ankur, and Dr. Harsimran Kaur, who has coordinated with me in ensuring that all this program comes through. And we have been planning this since last almost 3 months, but it was supposed to be happen on 3rd of December. So here we are. Before I invite Dr. Harsimran Kaur to say a few words, I like Dr. Venkat Giri KM, if he's there, to please unmute and express himself. Dr. Venkat Giri, please. Dr. Giri, are you there? Yeah, he's logged in. Okay, by the time he unmutes, over to you, Harsimran, for formal vote of thanks. And thank you very much. Unmute yourself, please.
So I read it somewhere that no duty is more important than that of returning thanks. I have been blessed with such an important opportunity today to propose a vote of thanks at the end of this wonderful academic session. On the behalf of Indian Society of Anesthesiologists and the organizing committee, I would like to thank Dr. Bhimeshwar, President ISA, Dr. Mahesh Sinha, Vice President ISA, Dr. Divetya, President-elect, Dr. Sukhminder Bajwa, Honorary Secretary, Dr. Manoj Kumar, Treasurer, Dr. Rakesh Garg, Editor-in-Chief, Dr. Venkatagiri, Chairman, Academic Committee, for gracing the webinar with their presence and contribution to make it a great success. I would also like to thank our moderators, Dr. Nishan, Dr. Ankur, and Dr. Monica for coordinating this webinar. An ignited mind is the most powerful weapon on the earth. This is got through education. So words are not enough to thank our distinguished speakers, Dr. Shalini Dheer, Dr. Christopher Hansbout, and Dr. Deepti Vissa for enlightening us with our presentations and including the recent evidences. So it was really informative. A special thanks to Dr. Naveen Malhotra for his constant guidance to shape the webinar, as it would have been impossible to organize it without your support. My deep sense of thanks and appreciation goes to all the delegates who were live with us and attended the event with that great enthusiasm and making it a great success. I'm sure everyone would like to look forward to many more collaborations of similar kind in the future. So thank you once again and have a wonderful day. Thank you.
Thank you, Dr. Harsimran. Over to you, Dr. Bajwa.
Thank you, Dr. Naveen, sir. The programs which was started 1.5 years earlier are taking a new turn and twist with the upside swing. And what a way to start with Dr. Shalini Dheer, madam, Dr. Christopher. He was so helpful. At least he didn't get the program, at least it didn't get sabotaged. That was a good gesture from him. Really thank him for this wonderful gesture. Then Dr. Deepti, and I think she got the maximum volley of the questions and she answered very beautifully, precisely and wisely, even admitting that one question about throwing it to the orthopedician field, that nice anyway, sometimes you have to rescue yourself. But all the more, because this is the new beginning of a new academic era for ISA, I definitely agree with Dr. Harsimran. We are going to collaborate with more of the international speakers. The sharing of the knowledge with the different countries will definitely enlighten even the practices in different parts of our country also. And there are certain good points in our country, certain good points from other countries. I think it's an amalgamation of these things which will help us grow more in all the academic fronts, because journals are not the exclusive source of growth. These interactions are more important. So in the coming days, we will be looking forward to all these collaborations with the faculty from the West and also from the other countries. And it's a nice beginning. And I really congratulate our dynamic immediate past secretary, Dr. Naveen Malhotra, who had started this program. He has built a platform now from where it's very easy for us to take off as a team as a whole. And I'm really thankful to entire governing council of mine, starting from our Dr. Bhimeshwar sir, who's the president ISA, then Dr. Mahesh Sinha, vice president, then Dr. Divetya is the president-elect, then my treasurer partner, Dr. Manoj, Dr. Rakesh Garg, our chief editor, then Dr. Venkatagiri, our academic chairman, and again, all the GC members who will be working with me and our entire team to taking this academic bonanza to some newer heights. So I'm really feeling very happy today. It really went off well. And I really thank all our three speakers and Harsimran, because to come to at this, sometimes it's difficult to part also, but we have to. So I now finally hand over the mic to Dr. Naveen Malhotra, who was because this program was finalized even before I took over as honorary secretary. It was his baby. So Dr. Naveen, kindly you deliberate upon the final point before we close.
So see you all next Monday, 12th of November for the class on ophthalmic anesthesia by Dr. Jayachandran. Good evening all. Long live ISA, Jai ISCN, Jai Hind. Thank you very much.
Good night, everybody. Good night.
Good night, everybody. Good night.